Hello, my name is Emily Eberly, and I am your moderator today for this special program called Protein Requirements in Protein Catabolic Critical Illness. I'd like to welcome you and thank you for tuning in to this very special program. And I'd like to thank BBRON for their support of this educational activity. This program is accredited for physicians, pharmacists, nurses, and dietitians. For physicians, this program is accredited through the ACCME and Synaptive for a 1.0 AMA PRA Category 1 credit, and this program expires December 31st, 2016. For pharmacists, this program is accredited through the ACPE for 1 contact hour. This program expires January 16th, 2017. For nurses, this program is accredited through the ANCC, the California Board of Nursing, and the Florida Board of Nursing, and expires March 6th, 2017. And for dietitians, this is accredited by the Commission on Dietetic Registration for 1 CPEU, and this program expires January 16th, 2017. Commercial support has been provided by BBRON Medical Incorporated. Regarding how to obtain your continuing education credits, for physicians, nurses, and registered dietitians, you can obtain credits for attending this self-study by going to www.saxtesting.com/ASPEN16. For pharmacists, please go to www.michiganpharmacists.org/ASPEN011716. Everyone will need to complete the evaluation and post-test, and upon successful submission, you will receive a certificate of completion. Now, I'd like to introduce you to John Hoffer, who is currently a project director at the Lady Davis Institute for Medical Research, and he is a senior physician for the divisions of internal medicine and endocrinology at the Jewish General Hospital at Montreal, Quebec. His academic responsibilities include professor, faculty of medicine, and associate professor for the School of Dietetics and Human Nutrition at McGill University. Dr. Hoffer was trained in internal medicine at McGill and obtained further training in nutrition and metabolism at Harvard Medical School, the Massachusetts Institute of Technology, and Brandeis University. Dr. Hoffer's research areas include amino acid and protein metabolism, the study of the prevalence and consequences of in-hospital protein energy and micronutrient deficiencies, and he is investigating the risks and benefits of high-dose vitamin C therapy in human cancer. A highly sought-after speaker, Dr. Hoffer has presented at nearly 100 national and international conferences, and as well he has published extensively in many peer-reviewed journals. Dr. Hoffer does disclose that he has received honoraria as a speaker for both Nestle and BBRON Medical, Inc. Dr. Hoffer, here's a very warm welcome to you. Are you ready to get started?
Hi everyone, I'm John Hoffer. I hope you find this presentation useful. At the end of this, I would hope that you would be able to do the following. First, you would understand and be able to explain the current contradictory recommendations that are out there regarding the amount of protein to provide patients who are critically ill. Additionally, you ought to be able to identify and name factors that would be the ones that would identify patients who are the most likely to benefit from optimum protein provision. And finally, to be able to create a physiologically rational, patient-specific clinical prescription for your patients in the ICU with regard to their protein and energy provision. Let me just summarize the content of what I'm going to be talking about with you. I'm going to explain that generous protein provision has long been recommended for critically ill people for many decades. Despite that long-standing recommendation, most ICU patients remain severely protein deprived. In the face of that situation, very recently some experts have advised that we limit all macronutrient provision to ICU patients. They recommend what's called permissive underfeeding in the intensive care unit. What I'm going to describe for you today is an attempt to dissect this opposite recent recommendation to what's recommended in the ICU, suggest how to identify which patients are the most likely to benefit from early protein provision, and then outline a rational way to analyze the situation for individual patients and how to treat them. Let's just remind ourselves what the goals of critical care nutrition are. First, to make biologically rational, clinically useful nutritional diagnoses, and then to match the nutrition therapy to the nutritional diagnosis. With that in mind, let's go ahead and explain the contradictory recommendations. I can do that by citing an article published in the very prestigious American Journal of Respiratory Medicine, Critical Care Medicine, published just about 2 years ago, entitled Gluttony in the Intensive Care Unit, Time to Push Back from the Consensus Table. The consensus table being the long-standing consensus that critically ill patients need lots of protein. I'll summarize what this editorial stated. Expert reviews, clinical care guidelines, such as the Aspen guidelines, have long endorsed early and generous nutrition for critically ill patients. Notwithstanding these recommendations, it remains true that energy and protein goals are rarely achieved in the crucial early days of an intensive care admission. Very recently, several large, high-quality randomized clinical trials were carried out which demonstrate that there is no benefit from supplementing the standard enteral nutrition of critically ill patients with parenteral nutrition that is designed to make up the deficits that have long existed. Consequently, these clinical trials of high quality prove that it's time to discard the consensus guidelines, and as the author of the editorial wrote, nutrition may be another treatment in the ICU where less is more. So what is he talking about? Best summary was published in a state-of-the-art review article published in the prestigious New England Journal of Medicine just about 1.5 years ago. And I'm showing here a figure from that review article in which 5 clinical trials, I won't go into them in detail at this moment, but laid out are 5 large high enrollment clinical trials. You can see the large enrollments, unusual in the intensive care unit to have such good numbers of patients enrolled in clinical trials, showing that in one group who received standard of care enteral nutrition compared to an active treatment group who received the standard of care plus supplemental nutrition therapy, early generous nutrition support simply didn't improve the short-term clinical outcomes in the ICU. These are all short-term clinical trials. I have analyzed some of the details of these 5 clinical trials, and indeed a 6th one was subsequently published, and I'm going to go through them with you, but if those of you who are sufficiently interested, this material is in press. In fact, I think it's just been published in a free access journal, which you could read if you're interested in picking through the fine details. Here's a summary table indicating 6 clinical trials. The years of publication are shown before, and they go by various acronyms: the Trophic trial, Eden trial, early PN trial, and so forth, in which there were patients who were critically ill, were randomized early in their ICU admission to either a standard of care treatment, which is on the top line, or the supplemental treatment, which is on the second line. And the goal shown was to demonstrate that, in fact, in each of the active treatment groups, the enteral nutrition plus parenteral nutrition, or in the first trial, trophic, that is low energy nutrition supplemented with full enteral nutrition, the goal was achieved of providing substantially more calories to the active treatment groups. So in a sense, they did separate the treatments. The treatments were very different in the active treatment patients and the control groups in these randomized trials. I then want to point out, what about the protein levels of intake? And so calculated on the final column on the right are the amounts of protein in grams per kilogram per day in each of these trials, both in the control treatment arms and in the active treatment arms. You'll see that the protein intakes in the active treatment arms were generally higher than in the control treatment arms. But what do those numbers actually mean in relation to the recommended amounts of protein that should be provided as based on clinical care guidelines going back for decades? I'll show that in the next column. What this indicates, if we go down it quickly, is that the protein provided in what's called standard of care ICU nutritional therapy, which is enteral nutrition therapy, the amounts of protein provided in the first approximately 1 week of admission to the ICU after nutrition was started is dramatically less than the most often recommended level of protein intake, or 1.5 grams per kilogram of normal body weight per patient. But beyond that, even though more protein was provided in the active treatment groups of these trials, in all but one of these 6 trials, the amounts of protein provided in the active treatment groups was still substantially less than half of what's recommended in the existing consensus care guidelines. Go further. We don't know exactly how much protein a critically ill patient needs, and certain analyses of the literature, such as I've carried out with my colleague Bruce Pistrian at Harvard, suggest that the amount of protein that may be optimum could even be 2.5 grams per kilogram per day. What if that's true? That suggests that in all of these clinical trials, the amounts of protein provided to these critically ill patients in the active treatment groups was less than half and maybe less than a third of what might be optimum to optimize their clinical outcomes. So where could we go with that? The contrary recommendations. Recommendation 1, avoid gluttony in the intensive care unit. That means don't feed patients too much. Feeding patients too much is bad. Best is permissive underfeeding. And indeed, in the New England Journal Clinical Review, a specific statement was made that the amount of protein that's provided is irrelevant to clinical outcomes. That's one set of recommendations. That's the current guidance of these experts publishing in leading clinical care journals. But the older recommendation is that critical illness greatly increases protein requirements. In fact, going by the Aspen clinical care guidelines, which are not different in the new ones that have just come out in January of this year, provide 1.5 grams of protein per kilogram per day, plus full calorie provision for non-obese patients, and for patients who are obese and critically ill, 2 to 2.5 grams of protein per kilogram of ideal body weight, that is discounting their excess adipose tissue, and then make it a hypocaloric regimen, 50 to 75% of energy requirements for those patients. Those are the 2 contradictory recommendations. I now want to try and help make some sense out of how this could come about, and could we put these together somehow? Well, let's start by summarizing what the randomized controlled trials showed. I think they nicely show, because these were clinical trials of high quality based on the criteria we use in evidence-based medicine. They were well designed, they were randomized, they were blinded appropriately, there were no sources of internal bias. They nicely show in the control groups who received standard of care that modern ICU patients are indeed severely calorie and protein deprived for the first week or 2 of an ICU admission. They also demonstrate that early generous calorie supplementation doesn't improve their clinical outcomes. However, what the clinical trials ignore is the question of what are the benefits of adequate protein intake. High calorie provision does not improve short-term clinical outcomes in the ICU. I'm ready to accept that, but I also have to point out that protein provision was inadequate in every one of these clinical trials. So here are contradictory recommendations. Avoid gluttony in the ICU, permissive underfeeding is best, protein provision is irrelevant, versus 1.5 grams of protein per kilogram per day. I would assume almost everyone listening knows that the recommendation for a healthy, normal adult who isn't critically ill is about 0.8 grams per kilogram per day. So the current thought, according to the older thinking, was that we would double, or if you look at the lower guidelines, triple the amount of protein in critical illness. So is protein provision irrelevant? Should we provide full energy provision in non-obese critically ill patients? And should we provide hypocaloric energy plus very high protein intakes to obese patients? These are now out there on the table. Can we make some sense out of them? To do that, I want to go right back to the nutritional pathology of critical illness. The body cell mass of the body, the protein-containing cells of the body, has 2 compartments. A peripheral compartment, which is about 80% of the whole body cell mass. That's the muscle mass of the body, a slowly turning over protein. And then so-called central or visceral proteins, which are rapid turnover proteins. Severe systemic inflammation, as occurs in sepsis, trauma, dramatically increases net muscle protein breakdown. It increases central protein synthesis because of the release of amino acids from the peripheral muscles to feed that central protein synthesis. And in fact, some nice studies suggest that the rate of central protein synthesis and protein synthesis for wound healing, for immune function, is even rate limited by the availability of free amino acids arriving from the peripheral store. And it's also an inherently inefficient transfer of amino acids from the periphery to the center, which leads to increased amino acid catabolism, urea synthesis, and nitrogen loss from the body, with a consequent rapid, dramatic muscle atrophy, leading to weakness, debilitation, and finally inadequate central protein synthesis to support healing and immunity. That's the general picture, supported by decades of high-quality, mostly consistent biological metabolic studies, but not clinical trials. So here's the human body. Body cell mass, 80% of which is muscle, 20% of which is viscera, is 50% of the body weight of a healthy young person. Extracellular fluid normally is about 20%, and so on. And that shows you a normal, healthy adult human. I wish. What happens to that individual when he becomes or she becomes critically ill? Here's a classic demonstration. It's typical of many studies that have been done showing that if we examine nitrogen excretion on the vertical axis, nitrogen excretion being a measure of protein catabolism in the body, and days, that with severe sepsis, trauma, or burns, the amount of nitrogen excreted per day dramatically increases. And that, of course, is demonstrating why the muscle becomes so atrophic so quickly in critical illness. The consequence shown in this little cartoon would be that a healthy muscular individual who is subjected to critical illness will pour amino acids from the peripheral stores, from the muscles, into the central proteins as a finely regulated mechanism for combating the process of critical illness, and at the same time be losing amino acids because of the inefficiency of the process, and will result in this pathetic critically ill patient who has no more muscle mass and not even enough amino acids to help his central protein functions. The point of all of this analysis is that the quintessential macronutrient to limit body protein catabolism in critical illness isn't calories, it's protein. We know, in fact, that high-level calorie provision does not improve short-term clinical outcomes in the ICU. Here are some of the studies that show that. So why this obsession with calories when protein is the essential nutrient in critical illness? It's a psychological question. How could we make sense of this? Let me start to analyze that by going into the review article that was just published in the New England Journal of Medicine, which indeed explained the hypothesis that underlay all of these large clinical trials that have recently been published over the last 4 or 5 years. Because all of these recent clinical trials were based on the therapeutic hypothesis that ICU patients need lots of calories. And that's the hypothesis that these clinical trials showed is wrong. So what was the reasoning that justified the immense expenditure of money, time, resources, careers in these large clinical trials? They were summarized in this review article. Number one reason was that energy expenditure increases in critical illness, so consequently, critically ill patients should get higher doses of energy, more calories. The second reason was that the hypocaloric state that these patients have promotes muscle wasting. And the third reason is that a large number of observational trials showed that deficient calorie provision is associated with worse clinical outcomes. These are the arguments stated in this review article. These aren't my arguments. They're not my arguments because every one of them is wrong. Yes, energy is important for efficient dietary protein retention. Almost everyone learns that in introductory nutrition courses. But there's loads of data showing that providing more than about 50% of a person's energy expenditure improves nitrogen balance very little further, and especially in critical illness. So once one's reached about 50% of a patient's energy expenditure in terms of what we deliver them, the additional benefit in a critically ill person of giving them more and more calories is questionable based on a large number of high-quality metabolic studies. The association between low calorie intakes and poor clinical outcomes is true, but it's actually much more likely to be explained by the fact that in every one of these studies, the patients who had low calorie intakes had even worse protein intakes. And so the same observations that justified providing more calories would have been more intelligently applied to providing the patients with more protein. I would argue that the premises on which these 6 clinical trials were carried out are seriously flawed. They're seriously flawed because most ICU patients have more than ample body fat. The average body mass index in the intensive care units on the range of 26. The percentage of patients who have depleted fat stores in modern ICU patients is less than 10%. Why would a person who has adequate body fat, and indeed the majority of whom have excess body fat, why would they need more calories? At the same time, many ICU patients have low muscle mass that is rapidly being catabolized at the same time that it's been well shown that their protein provision is grossly deficient. Why wouldn't these patients need more protein? So what's the bottom line? High calorie provision does not improve short-term clinical outcomes in the ICU. My suggestion was that this kind of research may be called proving the expected. At the same time, protein provision was inadequate in every clinical trial. So I want to come back to the question of why this obsession with calories, given the implausibility of the physiological arguments that were used to justify the clinical trials. And I want to go into that a little bit, partly for fun and partly because we could learn something about the way the scientific mind works. My suggestion is that these trials were so poorly designed and poorly understood is simple. Ignorance of nutritional principles, nutritional illiteracy, physiologically naive therapeutic hypotheses, and a sad failure to even define what the word malnutrition means. One of the biases involved in this whole picture is known as the streetlight bias. This is from an article published in Diabetes last year, but the streetlight effect is a well-known story of the inebriated man who stumbled out of the bar in the dark and he dropped his car keys down the street and couldn't quite remember where they were, and he was found by a policeman groping around under this street lamp, and the police officer said, "Sir, what are you doing?" I said, "I'm looking for my car keys. I dropped them." And the police officer said, "Well, where did you drop them?" He said, "Down the street, back there." And he said, "Why are you looking under the street light?" And the man said happily, "Well, this is where the light is." And my argument is that calories have been very easy to study for a number of various reasons, and proteins haven't been very easy to study, and it may be as simple as this kind of cognitive ignorance or cognitive bias. Another issue is what is, in fact, malnutrition. This whole question of the massive misunderstanding, vagueness, and misuse or varied use of the word malnutrition is covered and discussed perhaps too lengthily. Since I'm the senior of the article, I could say that in this review article, but I recommend to those of you to whom this question of definitions and semantics may be more interesting. It's certainly a problem where I am. I'm a professor at McGill University and I teach medical students, and the medical students, the clerks, they come up onto the wards and they are faced with starving patients. I'm not talking about the ICU only, I'm talking about the active wards. This is a tertiary care teaching hospital. It's a high quality, modern institution. And yet about 1 in 4, and some of our studies suggest more than that, patients on the wards are suffering from protein energy malnutrition. And the students do not know what to think about it. This is the disease that they are looking at. These are two examples of protein energy malnutrition. The cases look identical, but there's an important difference between them. The case on the right is a man starving with advanced and potentially even terminal advanced protein energy malnutrition in the Netherlands during the end of the Second World War. And the almost identical picture is of a patient in an intensive care unit in Boston City Hospital, a major Harvard teaching hospital. It's the same disease, but obviously the pathways that got to them must be very different. And unfortunately, the nutritional illiteracy of many physicians is really, unfortunately, too great, so that my medical students will be pointing out or thinking or wondering what to make of this malnutrition on our wards, and the staff man, their professor, won't see it. And very quickly in the hidden curriculum of medicine, the students learn that what they're seeing can't be important because their senior residents and their staff don't think it's important, and the malnutrition vanishes. Fortunately, we have a wonderful consensus statement published by the Academy of Nutrition and Dietetics and the American Society for Parenteral Enteral Nutrition, published 4 years ago, which now is finally starting to apply some reasonable, rational, and discernible ways of diagnosing different kinds of malnutrition based on the physiological states. And I think this may be helpful, and I can only second the recommendations that were made there. When we talk about what is malnutrition, I'm getting at the point that the malnutrition that is being treated in intensive care units remains poorly identified, characterized, and that is troubling to the design of clinical trials. That's academic medicine's streetlight bias. Muscle mass is what's not looked at. Fat and body mass index is the only thing that the light is being shown on. The definition of malnutrition in all of these clinical trials I used made no mention of muscle mass, even though the biological, physiological data we have suggests that it's the patient's muscle mass that's the crucial determinant of their prognosis and their outcome. For example, let's look at these clinical trials. I went down them and simply looked at how they defined malnutrition. After all, if you're giving nutritional therapy, you want to have a nutritional diagnosis and base the therapy on the diagnosis. And this is how academic medicine currently defines malnutrition, not defined in 2 of the studies. And in the other studies, malnutrition was defined as a body mass index less than 18 or 17 or even 16. To me, that isn't a definition of malnutrition. And if it is a definition of malnutrition, then about less than 5% of all patients in modern ICUs have malnutrition. There's a conceptual problem pervading this whole field. I call this academic medicine's blind spot. Going through the critical care literature, there are nearly countless examples in editorials and articles and reviews in which the words nutrition and calories are used as if they mean exactly the same thing. When patients were enrolled in clinical trials, the question of what was their body cell mass was completely ignored. Furthermore, any physiological evidence about the importance of protein nutrition was ignored and discounted on the reasoning that if the data isn't derived from a randomized clinical trial, it's not evidence, and so it can be completely disregarded. As a consequence of this bias, we have numerous randomized trials in the ICU of early nutrition support using high-calorie therapy, many studies with negative results. We have dozens of trials of glutamine in the ICU with indeterminate or negative results. How many clinical trials have been carried out in the last 30 years of high-quality, optimal clinical trial designed to determine optimum protein provision? None, or at the most, perhaps one that came out last summer. So the question of what is malnutrition is an important one for everyone to contemplate when they use the word. If it was up to me, I would just eliminate the word malnutrition. It's so contaminated with ambiguity that one should use specific terminology. That's my opinion. Or use the consensus statement that divides malnutrition into starvation-related malnutrition. That would be chronic pure starvation as in anorexia nervosa. Chronic disease-related malnutrition, we might sometimes talk about that as cachexia. And then acute ICU-type, highly protein catabolic states. I want to quote this wonderful statement from M. Fisher. According to the American Society of Parenteral Nutrition and the Academy of Nutrition and Dietetics criteria, the diagnosis of malnutrition includes an evaluation of muscle and fat. The role of inflammation not only enhances catabolism of muscle and fat, but it interferes with their anabolism. It's pointing to the crucial importance of looking, examining, determining the patient's body cell mass, not their fat mass. Dietitians and other nutrition professionals need to understand techniques to identify losses of muscle and fat, to incorporate them into appropriate diagnosis, as I've just gone over. Proper training is imperative to correctly identify muscle and fat wasting in a good, proper, reliable way. Nutrition clinicians should begin to incorporate these practices into their patient assessments and care plans right now. And so the cardinal feature of starvation disease isn't fat mass, it's muscle atrophy. There's a normal muscle and there is an atrophic muscle. It's not hard to distinguish between them. To help people remember, I often think of the great 19th century composer Chopin, who was composing one of his etudes at the keyboard. And then I can remember the 6 causes of generalized muscle atrophy. Cachexia, or systemic inflammation, which would be in its greatest form what we see in the intensive care unit with SIRS and systemic inflammatory response syndrome. Certain conditions of hormone excess, such as high-dose glucocorticoid therapy or deficiencies, old age sarcopenia, protein energy malnutrition, otherwise known as simple starvation disease, inactivity and disuse muscle atrophy, and neuromuscular disease, the 6 causes. CHOPIN. And which of those is the one that applies in the intensive care unit? Generally speaking, I would suggest it's cachexia, systemic inflammation. The average ICU patients now in general ICUs, not trauma centers, includes old age with the sarcopenia, the inevitable muscle loss of old age. And many patients come into the ICU with pre-existing diseases that had led them to be starving. So when I see a patient like this is a patient who obviously is suffering from severe generalized muscle atrophy. Frédéric Chopin looks at this man and he says, which causes are responsible for this patient's generalized muscle atrophy? Is it cachexia, hormonal problem, old age, protein energy malnutrition, inactivity, neuromuscular disease? In his case, it's pure starvation disease. This is from the famous Minnesota starvation experiment published in 1950. So he doesn't have any cachexia. He doesn't have a hormone problem. He's not old. This man is 22 years old. Not inactive. He had an active treatment program. All this is simple starvation disease. In this case, the diagnosis is clear. Other cases, not so clear. Here's a patient I saw on the wards of our hospital. As a consult, I was asked to see this obese woman to see if she needed any nutritional assistance. When I took a long look at her shoulder and her upper arm, I saw that she was obese, but that she had severe protein energy malnutrition. She had severe muscle atrophy. Look at her humerus. Look at her arm. I lifted her arm. She gave permission for this photograph. And the fat, her skin folds fall away under gravity, and you see the empty skin folds. Sure, she's lost a lot of fat, but she had loads of it on board. But I could put my hand around this woman's arm, her humerus. I could almost join my fingers. That is a severe case of malnutrition. Which of the criteria fit? Was it cachexia, hormone problem? We can work it out from the physical examination, the medical history, and so forth. The real point I want to make is using the criteria present in academic medicine today, this patient is well nourished, and she's not. So which ICU patients would benefit the most from adequate protein provision? Can we think about that? Suggests the high priority patient would be one who has a subnormal muscle mass. Is it due to cachexia, hormone excess deficiency, old age, protein energy malnutrition, inactivity? It doesn't matter what it's from. If the patient has generalized muscle atrophy, they're at risk. And so how do you identify those patients? Physical examination, discounting any concurrent fat excess, because obese patients can have severe generalized muscle atrophy. The second kind of high priority patient is one who is suffering from intense protein catabolism. High priority patients. Evaluate the patient's muscle mass, do a meticulous physical exam. The physical examination shouldn't take more than 2 minutes. It's not a difficult skill to learn. Don't be fooled by the patient's fat. That's the only thing or any anasarca or volume excess from the resuscitation fluids. There's certain parts of the body you can examine. It's not hard. Anthropometric measurements are recommended now by many of the dietetic organizations. They're fine, but I wouldn't allow them to replace just the clinical skill and recognition of a pattern of muscle atrophy. And for research purposes, it's becoming now popular to use imaging techniques such as ultrasound or even CT scans. They're fine for research, but I think they should only supplement a clinician's own clinical astuteness, because it's so easy to identify generalized muscle atrophy. The question is, does the light go on? Do you realize that there is a problem there? The second issue is to evaluate how protein catabolic the patient is. Right now, that's a problem in my opinion. All the current critical illness scores have no proven relationship between their criticality scores and the actual rate at which patients are losing body nitrogen. And we really need to develop scores that do correlate with the catabolic state, because I predict that's one of the crude determinants of which patients need or would benefit from generous protein provision. Currently, the best we have is urinary nitrogen excretion, and I recommend this excellent review article by Dr. Dickerson, which goes the ins and outs and practicalities of doing nitrogen balance measurements in the ICU. Here's a pattern from my mentors, George Blackburn and Bruce Bistrian at the New England Deaconess Hospital in Boston, published in the JPAN many years ago. And what they did was suggest that when you decide which patient needs nutritional support, which in those days meant high protein, high amino acid, parenteral nutrition, generally speaking in the ICU, 2 axes I've just pointed out to you were used. One was the rate of nitrogen excretion, which of course is the indicator of how protein catabolic they are, and the other determinant was the category of malnutrition. And what they initially suggested way back then, 30 years ago, was to use a person's percent weight for height, and that was naive. Let's make that severity of muscle atrophy. That's really the key. If you do that, then you can determine which patient you want to give the high protein nutritional supplementation to based on some combination of severe catabolism and severity of muscle atrophy. And you can do a subjective global assessment of which patients would qualify. And in practice, it's very easy to come to the decision. My plea is that we do need evidence-based medicine to start to be applied in the ICU, pending adequate randomized controlled clinical trials that aim to determine what the optimum protein requirement is and then test it in adequately controlled trials, well-designed trials, along the lines of what was done before, but now not worrying about the calories. We already know that critically ill patients don't need extra calories. What they do need, or what we need to find out if they need, is extra protein. So here's a suggestion for how to do that. For any patient whose body fat store is adequate, let's say their body mass index is over 18, these patients still have maybe 5–10% body fat, then hypocaloric, high protein nutrition is safe. It's most rational on physiologic principles, and it's consistent with the results of all these recent calorie intervention clinical trials, because they enrolled patients right down to body mass index of 18, and they didn't show that any harm was done by providing them with hypocaloric nutrition. Why not just follow Aspen's guidelines for obese patients, for all patients who have an adequate body fat store? We already have guidelines for obesity, but why should we not use those guidelines for any patient who has enough fat on board? Second, we should choose patients in these clinical trials who have low muscle mass and/or major protein catabolism. For example, just to get to that point, here is a recent clinical guideline from the Aspen about nutrition support for the hospitalized adult patient with obesity. The recommendations 2 to 2.5 grams protein per kilogram of normalized ideal body weight per day plus hypocaloric nutrition. That recommendation to me is rational, logical and safe, but it should apply to all patients, not just obese patients. That's the recommendation that deserves to be tested with good, high-quality clinical trials. It's rational because we want to avoid the risk of toxic energy overfeeding. So therefore, limit calorie provision to 2/3 of estimated energy expenditure. We're just keeping in line with the results of these large clinical trials when we do that. And now use parenteral nutrition to provide 1.8 grams of mixed amino acids. And an amount of dextrose, I just simply calculated what would give about 15 kcals per kilogram per day. It would be about 3 grams of dextrose per day as soon as possible after the patient has been stabilized upon admission to the ICU. And then one can adjust the parenteral nutrition as the enteral nutrition slowly comes up back towards your goal. That asterisk is to point out that if you provide 1.8 grams of mixed amino acids as parenteral nutrition, you're actually providing 1.5 grams of protein, as explained in that review article. It so happens that just in the JPEN, just in the January edition of the article, Dr. Halen from Kingston, Ontario, did a comparison looking at exactly that thing. He looked at macronutrient intake of proteins and calories. He looked at the adequacy of the protein intake and mortality rates, and he showed that as protein adequacy improves, mortality rate continues to drop, whereas that's not true as you increase calorie provision, as was indeed indicated by these multiple controlled clinical trials. But my question is, where did he get adequacy from? Who knows what adequate protein provision was? And indeed, the level of adequacy that was chosen for this particular analysis is questionable. What's unknown is what is the adequate amount of protein to provide patients. It could be 1.5 or 2.5 grams per kilogram per day. Precautions with high protein intake and calorie provision and hypocaloric nutrition. If the patient has significant fat depletion, we can't ignore the fact that we have to maintain their body fat stores. Second, patients with severe liver dysfunction, there can be issues with handling the load of ammonia that's produced in order to convert it to urea. So patients with advanced liver disease or hypoperfusion of the liver or certain inborn errors of metabolism or certain drug therapy, these patients have to be studied cautiously, and I wouldn't enroll them in these particular clinical trials. But renal insufficiency is not a limiting fact at all because all modern ICUs have renal replacement therapy available. This is critical care nutrition's challenge: to make biologically rational, consistent, and clinically useful nutritional diagnoses. To do that, follow these physical assessment guidelines that I've gone over with you. Make protein catabolic assessments. Nitrogen excretion is the best we have at the present time. Then develop nutritional prescriptions that are appropriate to the nutritional diagnosis based on the patient's muscle mass, their catabolic state, and then validate these prescriptions by designing and carrying out nutritionally literate clinical trials, unlike what I maintain are the illiterate trials that we've had published and now highlighted in these recent prestigious medical journals. Critical care nutrition's failure has been an obsession with a biologically implausible diagnostic and therapeutic paradigm. The paradigm has now been tested repeatedly, and it's wrong. This is the wrong paradigm. Malnutrition is not enough calories, and nutrition therapy is give more calories. We now know that just isn't true. There are more plausible paradigms that should be implemented and tested, and I've outlined one that makes sense to me. See if you can do better, improve on it. And what can you do right now in your own clinical practice while you're waiting for academic medicine to develop nutritional literacy? First, I suggest you adhere to the current AND, ASPN guidelines, physical assessment of every patient, and document the findings in the medical record. Don't wait for the physicians to start doing physical exams of the patients if you're not a physician. And then match the nutrition prescription to the nutritional diagnosis. I just made up what I would call as SGA, a subjective global assessment pattern, that is just a throw out as for how one might document this kind of situation. Is the patient being actively treated or not? Yes or no, because some are going to die. Those patients aren't an issue. You have to know what your goals are of therapy. Assess the patient's muscle mass using a subjective approach. Is it normal? Is there moderate atrophy? Is there severe atrophy? Looking at the various important muscle groups. Determine, using common sense from the history and physical exam, which of the 6 causes of generalized muscle atrophy are acting and responsible so that you can mitigate those that are mitigatable. Determine whether the protein catabolism is mild, moderate, or severe. And then also have a look at the subcutaneous adipose tissue mass. This is a development from Gigi Boy's famous subjective global assessment, but honed to the ICU, where too often people are misled by the layers of fat and don't discern the severe muscle atrophy underlying it. This elderly patient has severe muscle atrophy, caused and contributed to by moderately severe protein catabolism, sarcopenia, disuse muscle atrophy, and high-dose dexamethasone therapy. He has adequate or increased fat mass. So it's CHO&I. And this patient urgently needs high-protein, low-calorie nutritional support. He fits perfectly into existing guidelines from Aspen. This normal weight man has normal muscle and fat mass, but extremely severe protein catabolism. It's all SIRS. But the catabolism is so severe, this patient urgently needs high protein, low calorie nutrition support. This elderly patient is on a ventilator because his end-stage COPD was exacerbated. He has muscle atrophy due to his adapted protein energy malnutrition, almost a routine for patients with advanced COPD and respiratory failure. He has sarcopenia and he has chronic steroid therapy, but he has only mild protein catabolism. He's in the ICU because he needs a ventilator and he's severely fat depleted. Well, this patient would need full energy support, and I'm not even sure he needs a very high protein provision rate. In summary, several high-profile randomized clinical trials have been cited to support the radical and unfounded recommendation that critically ill patients ought to be permissively underfed all nutrients. I suggest that these trials do show that early high-calorie provision doesn't improve clinical outcomes, but all these regimens were dramatically protein deficient. In fact, generous early protein provision is highly likely to be beneficial for certain specific patients, but unfortunately, as of this date, no large appropriate clinical trials have ever been carried out. We're waiting for them. The definition of malnutrition and the indicators for protein and energy provision need to be made more clear and need to be made uniform in the design and execution of clinical trials. Malnutrition is not equal to a low body mass index. All ICU patients require bedside assessment of their body composition and catabolic rate. It should go into the medical record, and dietitians and nurses go ahead and do it because MDs who aren't nutritionally literate simply aren't interested, so don't wait for them. The nutritional status and catabolic profile should then direct the prescription that's made to treat the patient. There is an urgent need for nutritional literacy in the critical care field and an urgent need for nutritionally rational clinical trials to identify and then verify if is it really true the optimum level of protein provision in critical illness. Why do parenteral and enteral solutions of free amino acids provide 17% less protein and energy than intact protein? I just want to take a second as a postscript, though I encourage you to read this superb article published in the American Journal of Clinical Nutrition in 2011. It's really simple. When amino acids join to form protein, they lose a molecule of water. That's the peptide bond being formed. That means that in free solution, crystalline individual amino acids have a higher molecular weight. They're heavier than when they are bound to protein. And a calculation shows that if you join them fine proteins, the actual amount of protein substrate that's being provided in these free amino acid solutions is about 17% less. They're diluted by the water in the free amino acids. I'd like to thank you all very much for attending this educational activity.
Thank you, Dr. Hoffer. I would like to remind everyone about how to obtain your continuing education credits. For physicians, nurses, and registered dietitians, to obtain your credits for attending this self-study, please go right here to this hot link, which is www.saxtesting.com/Aspen16. The hot link will take you right to the test. For pharmacists, please click right here on this hot link, which is www.michiganpharmacists.org/Aspen011716, and you will be taken straight to your test. You will need to complete the evaluation and post-test, and upon successful submission, you will receive a certificate of completion. And a PDF version of the slides will be made available to you right here at this website, which is www.sharingknowledge-1.org. I'd like to thank you very much for your time, Dr. Hoffer, for all of the material that you've covered with us today, which is vitally important towards the understanding of the protein requirements for critically ill patients. And most importantly to you, our online viewer of this program, I'd like to thank you for your time and your very thoughtful attention.